Welcome to the workshop, The Impact of Gut Microbiome on Transplant or CAR T-Cell Therapy. My name is Sue Stewart, and I'll be your moderator for this workshop. It's my pleasure to introduce today's speaker, Dr. Melody Smith. Dr. Smith is a board-certified, fellowship-trained hematologist-oncologist and an assistant professor of medicine in the Division of Blood and Marrow Transplantation and Cellular Therapy at Stanford University School of Medicine. In 2021, she established the Smith Lab, an independent lab investigating CAR T-cell biology to gain insights that may help to improve patient outcomes. Please join me in welcoming Dr. Smith.
Thank you, Sue, for the introduction and for the opportunity to present our research here at this seminar and symposium. I'll be talking today about the impact of the gut microbiome on transplant or CAR T-cell therapy. And as was mentioned, I am an assistant professor at Stanford University. Here are my disclosures. So the objectives of today's talk will be to discuss the following: the role of the intestinal microbiome in outcomes following allogeneic hematopoietic cell transplantation or chimeric antigen receptor T-cell therapy. To also discuss the impact of allo-HCT and CAR T-cell therapy on the intestinal microbiome. And then finally, to wrap up with interventions, including diet and lifestyle changes that promote a healthy microbiome. So for the first objective, the role of the intestinal microbiome in outcomes following allo-HCT and CAR T-cell therapy, I'd like to just begin with an overarching understanding as it relates to cancer immunotherapy, which are any immunotherapies that harness the body's immune system in order to fight cancer. So here you can see this is a plane that's flying close to the surface of the ocean. You can see its shadow, it's pretty close. And think of this as a plane that is flying below the radar. This plane is cancer, and this plane is flying below the radar detection of the immune system. Naturally, the immune system, the cells within the immune system, such as T cells, their job is to detect cells that are malignant and eradicate them. But cancer forms when these cells form and the immune system does not pick up that they're starting to develop. Cancer immunotherapy, however, is a class of immune-based therapies that harness the immune system's ability and enhance it such that it can now bring up the cancer higher so that the immune system can detect it. And these therapies have really led to novel approaches for us to be able to fight cancer. Encompassed in cancer immunotherapy are, this is not an exhaustive list, but these are like the big categories that encompass cancer immunotherapy. The oldest cancer immunotherapy is allogeneic hematopoietic cell transplantation, which is a therapy that is used for primarily blood cancers, either for patients with high-risk blood cancers or those who have blood cancers that have relapsed after upfront chemotherapy. Then there's immune checkpoint blockade, including anti-PD-1 and anti-CTLA-4, which were the first, and now there are many others that are being investigated. These are most commonly used for solid tumors, but they're also used in the case of treatment for lymphoma. And then finally, there's adoptive cell therapy, which encompasses both chimeric antigen receptor or CAR T-cell therapy, as well as TCR T-cell receptor-based therapies. Today, I'll be focusing on allo-HCT and CAR and really spending the bulk of the discussion there. So first for allo-HCT, just again, a brief overview for those who are less familiar with allo-HCT. So this is a therapy where in patients who need it, the recipient who would be undergoing the allo-HCT, their body is conditioned with one of the following or a combination of the following: total body irradiation, chemotherapy, or antibodies. Once their body is conditioned such that it ablates the recipient's own immune cells, and marrows to varying degrees depending upon the type of conditioning regimen they're receiving. They then receive donor hematopoietic stem cells from an HLA either matched or half matched, depending upon the type of transplant they're receiving, from a donor. And these cells are infused into the recipient. So for a conventional allotransplant, the recipient receives all of the cells from the donor. So all of these cells are given without selection. There's no removal of T cells, and the rate of graft-versus-host disease, or GVHD, in this type of conventional transplant can range from as low as 40 to up to 60%. And so what we know about transplant, and this is CIBMTR data showing mortality 1 year following transplant, that the leading cause of death in the first year after transplant is relapse from the primary or underlying disease for which the patient received the transplant, followed by death due to graft-versus-host disease. GVHD mortality has dramatically decreased over the years as we've been able to develop new therapies to better treat it and new transplant strategies to prevent it. However, relapse remains an ongoing factor in terms of post-transplant morbidity and mortality. And so much of the focus of allotransplant research focuses on really those two things: enhancing graft versus leukemia activity, which is intended to help decrease relapse, and also mitigating or decreasing graft versus host disease. Adoptive cell therapy, so just a brief review of CAR T-cell therapy. So what is a CAR, or why is it called a CAR? Why is it called chimeric? So the chimera, just for a brief review back to Greek mythology, the chimera was this structure, and this is a plate from the Louvre, which shows a chimera as reported in Greek mythology. So this is a fire-breathing high creature that consisted of the head and the body of a lion. So you can see the head and the body of the lion. Protruding from the back is the head of a goat, and sometimes, here you can see there was the tail was a snake's head. And what chimera simply means is that you are combining different things that are not naturally together, and they're all together. So chimeric is because a lion, a goat, and a snake aren't usually together. Similarly, a B cell receptor, which is the CAR receptor, is not usually in a T cell. So that's why it's considered chimeric, because T cells have T cell receptors, but by introducing a chimeric antigen receptor into the T cell, you're making it chimeric. This technology to introduce the CAR into the T cell is usually a viral-based technology, and the portion of the receptor outside of the T cell that binds the antigen or the marker on the tumor is what's called the CAR. So here are 5 CD19 CAR T-cell constructs that are currently approved by the FDA, and here are the names of them. So they have both generic names, such as axicabtagene ciloleucel, but then commonly referred to as Yescarta, and I have the names for the various ones, and their disease indications: large B-cell lymphoma, follicular, and then the same receptor, brexacabtagene autoleucel, is also called Tecartus. It's used for mantle cell and B-cell acute lymphoblastic leukemia. So you can see the various CARs. This is their structure. They have quite a few similarities. Most of them have the same CAR receptor, but some of the internal working and design of these CARs vary from CAR to CAR, which really is important to keep in mind because that is what mediates different functional benefits and functional activity of those CARs. So all of these CARs are indicated for non-Hodgkin's lymphomas or B-cell acute lymphoblastic leukemia. And this therapy has led to significant advances for patients with hematologic malignancies. So for patients with relapsed or refractory disease, it's really revolutionized treatment options. And there are 7 CARs that are now FDA approved, so 5 for CD19 malignancies and 2 for BCMA targets. That's for multiple myeloma. And we have, really encouraging data. This is an older photo. Emily Whitehead, who was the first pediatric B-cell acute lymphoblastic leukemia recipient of CAR, this is a photo from when she was 11 years post therapy. She's now in college and still cancer-free, so that the therapy for her led to long-term disease remission. And similarly, there are reports of patients, adult patients as well, who have been in remission after CAR T-cell therapy for more than a decade. This was from 2022. So really a promising therapy and a game changer for our ability to treat patients and lead to better outcomes. However, there are still some limitations in that, and this is representative of data from a publication in 2021 looking at patients with non-Hodgkin's lymphoma who received CAR T-cell therapy, that about 60% of patients with this therapy may still relapse, and most commonly relapses happen within that first 12 months or a year after CAR T-cell therapy. And next, the other thing that is a limitation, which we've gotten much better at managing, but is still an ongoing issue, is CAR-related toxicity. So cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome, or the neurotoxicity that we watch out following CAR T-cell therapy. They have their peak of incidence and presentation within those first 2 weeks, but can happen anytime during the first 30 days after CAR T-cell therapy. So still an area that we need to continue to address to improve upon. So given the various limitations, both for allo-HCT and CAR T-cell therapy for hematologic malignancies, we continue to investigate ways to improve patient outcomes. And one approach that we are focusing on, particularly in my research as well as both in the clinic and the lab, is whether endogenous factors, so factors that are within the individual, within the host, alter patient response. And one of those endogenous factors that we're interrogating is the impact of the intestinal microbiome. So what is the intestinal microbiome? It was declared as one of the hallmarks, added as one of the hallmarks to cancer therapy, and really has exploded in terms of our knowledge base in various clinical indications, including in cancer therapy. So the intestinal microbiome are the microorganisms that live in the human body, and that includes bacteria, viruses, and fungi. A couple notable facts about the microbiome is 10 to the 14th, there are 10 to the 14th microbes per person, and microbes make up about 3% of the human body mass, with the majority of these microbes residing in the GI tract, from the oropharynx all the way through the gut. And there is a growing body of literature, this is just a very tip of the iceberg, highlighting some of that body of literature as it relates to the microbiome and cancer immunotherapy, allotransplant, and immune checkpoint blockade. But there's really a wealth of literature highlighting the implications, the role, and starting to delve into mechanisms of the microbiome in these clinical indications and therapies. So in summary, cancer immunotherapies are a class of cancer treatment that enable the immune system to target cancer that may have otherwise gone undetected by the immune system. Allo-HCT and CAR-T are cancer immunotherapies that offer key therapeutic options for patients with blood cancers. And the intestinal microbiome, which consists of the bacteria, viruses, and fungi in the host, they've been implicated in the patient's response to these therapies. So next I'm going to talk about the impact of allo-HCT and CAR T-cell therapy on the intestinal microbiome. So again, as a broad overview, we wrote this review earlier this year that really highlights the intestinal microbiome and CAR T-cell therapy. So what we know is that one factor, which I'll touch on a little bit, that impacts the microbiome both for allotransplant and CAR T-cell therapy are antibiotics, because they induce something called dysbiosis or alterations in the microbiome. And the way in which they impair outcomes for transplant is that we've noted that in patients with exposure to certain antibiotics prior to allotransplant, they have increased mortality due to graft-versus-host disease of the gut, as well as increased antibiotic resistance. For CAR T-cell therapy, specific antibiotics have been associated with decreased survival, both progression-free and overall survival, as well as increased neurotoxicity. And so what we hypothesize is that these antibiotic exposures lead to a loss of some of the normal constituents, what we call commensals, within the gut. They alter some of the substances that those bacteria produce into the microenvironment, and so they decrease diversity and also result in increased antibiotic stewardship. That's what we have identified in our research, as well as others have also. And one of the strategies that is a potential implication from these findings is that antibiotic stewardship, or really being thoughtful about the type of antibiotics that we give patients, as well as eventually maybe giving back specific consortia of healthy bacteria could be beneficial. But more research needs to be done to get to that. Let me just talk to you a little bit about some of that data as it relates to allotransplant. So one feature of the microbiome is something we call diversity, and diversity sounds like what it is, meaning different types of bacteria. So when the microbiome is including different types of bacteria, that's a healthier microbiome. So that's called high diversity. More different types of bacteria means your microbiome has all the different members that it should have that are doing their distinct roles. A lower diversity is not a healthy microbiome. And what we found is when we look at allotransplant overall survival, right around the time of engraftment, looking at low diversity, patients with a low diversity versus a high diversity of their microbiome, those patients with a low diversity microbiome or even intermediate do worse compared to those patients with a high diversity microbiome. And there's a lot of different things that can impact the diversity of the microbiome, including diet, medications, various exposures to medications, including antibiotics, as well as others. And another thing that has been evaluated in terms of low versus high diversity, again, with higher diversity being a healthier microbiome, you can see when we look at lethal graft-versus-host disease, so graft-versus-host disease in patients that was associated with mortality, lower GVHD, lower diversity was associated with a higher risk of mortality from graft-versus-host disease compared to those patients with a higher diversity. And then one other thing that I wanted to highlight in terms of that is, again, antibiotics. Antibiotics impact cell therapy, but there's also a publication that showed that exposure to various medications, not just antibiotics, but lots of different antibiotics that patients receive, has a differential impact on the intestinal microbiome. This was analysis from a cohort of transplant patients looking at everything from high blood pressure medications, diabetes medications, and kind of doing a score calculation to see which antibiotic or which medications impacted the microbiome most. And so if you're really interested in delving into all different types of medications, this paper analyzes that. And it's not just antibiotics that impact the microbiome, but antibiotics are the most damaging. In particular, the disruption that antibiotics can cause is called dysbiosis, as I mentioned earlier. And antibiotics, especially those aimed at obligate anaerobes, which are microorganisms that live in the gut and survive in the presence of oxygen, these antibiotics greatly impact those beneficial gut bacteria that play a crucial role in maintaining health. So obligate anaerobes are really important for the immune system and other critical roles, but for the purposes of today's talk, I'll just highlight their role in the immune system. And so if you can imagine antibiotics that we call anaerobe-targeting antibiotics that disrupt these obligate anaerobes, they've been linked to the response to cell therapy. And so we'll talk about that more. So first, these obligate anaerobe antibiotics, so imipenem and piperacillin, those are obligate anaerobe-targeting antibiotics. It's been found that in allotransplant setting, they did not impact overall survival, but exposure to these obligate anaerobe-targeting antibiotics was associated with a higher risk of graft-versus-host disease compared to no antibiotics or those antibiotics that did not impact obligate anaerobes. So obligate anaerobe antibiotics do have an association with increased graft-versus-host disease mortality. Likewise, in the setting of CAR T-cell therapy, we also analyzed similar antibiotics, piperacillin, tazobactam, imipenem, and meropenem, which are obligate anaerobe-targeting antibiotics. And again, In the setting of CAR T-cell treatment in the 4 weeks prior to CAR T-cell therapy, exposure to these antibiotics is associated with decreased overall survival. We looked at a subset of patients who received cefepime, which is an antibiotic. Many of these, I just want to say, many of these obligate anaerobe antibiotics are really important antibiotics that are necessary to consider giving to patients who don't have immune cells, what we call neutropenia. And if patients have a fever, they're neutropenic, you need to give them antibiotics because their immune system can't fight infection. So that's why these obligate anaerobe antibiotics are often used. But another antibiotic that can be used in the setting of a neutropenic fever is called cefepime. It's a really good antibiotic. It's broad spectrum, but it does not disrupt those obligate anaerobes to the same degree. So we looked at exposure to cefepime compared to no antibiotics compared to the obligate anaerobe or anaerobe-targeting antibiotics. And what we found was that cefepime was not associated with decreased survival, whereas those obligate anaerobe antibiotics were. And I think this is a really important piece of information because it helps to address the question as to whether exposure to these obligate anaerobe antibiotics was just highlighting sicker patients who got antibiotics and did worse, as compared to whether what the antibiotics were actually targeting was the issue. And this data showing cefepime exposure, which does not target the obligate anaerobe antibiotics, not lowering overall survival or progression-free survival, suggests that it's not just antibiotic exposure, but what the antibiotics were targeting that we are seeing this impact here. This data has also been reaffirmed by 2 separate publications. Our initial finding from 2022, another group that was an international cohort of patients who got CAR T-cell therapy looked at no antibiotics, low-risk antibiotics, and high-risk antibiotics, much of which were those obligate anaerobe-targeting antibiotics. And here you can see in patients exposed to the high-risk antibiotics, their proportion of survival was lowest, so they had the worst outcome compared to the 2 other groups, these patients exposed to high-risk antibiotics. And then another analysis looked at no antibiotics, cephalosporins, such as cefepime, or anaerobic targeting antibiotics, and again found that anaerobic targeting antibiotic recipients did worse compared to the 2 other groups. So again, anaerobic antibiotic exposure before CAR T-cell infusion has been associated with decreased overall survival. The other thing is that anaerobic antibiotic exposure before CAR T-cell infusion is associated with increased neurotoxicity. So we looked at cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome, or the neurotoxicity that we watch out for after CAR T-cell therapy, and looked at anaerobic targeting antibiotics and didn't see any association with CRS. However, when we looked at neurotoxicity, we did see that patients who were exposed to these antibiotics, yes, in blue, had worse survival compared to those patients who did not receive one of the obligate anaerobe targeting antibiotics. A separate publication did a similar analysis looking at the cytokine release syndrome versus neurotoxicity, and they also found that exposure to the high-risk antibiotics was associated with increased neurotoxicity. And then finally, I'm just highlighting that we have looked at specific bacteria, looking at bacteria as well as the metabolic pathways that the bacteria utilize, looking at what they secrete into their environment. And we've found that both the specific bacteria and their metabolites, these compounds that the bacteria produce, both have been linked to how well patients respond to CAR T-cell therapy. So in summary, anaerobic targeting antibiotic exposure during allo-HCT is associated with decreased survival and increased graft-versus-host disease mortality. Exposure to anaerobic targeting antibiotics in the weeks preceding CAR T-cell therapy is linked to decreased survival and increased neurotoxicity. This data provides potential insights regarding antibiotic stewardship for clinicians caring for CAR T-cell and allo-HCT patients. I think one important point that I want to highlight is when patients have a fever and they're neutropenic, they need antibiotics. That's not a question. What this data suggests, however, is that we may be able to select antibiotics that are less damaging to the gut and associated with less harmful outcomes, not that we shouldn't give antibiotics, because these antibiotics are life-saving and critical when patients don't have immune cells to fight an infection. Ongoing studies are investigating the mechanisms behind these antibiotic associations, and we're currently doing some of this work in my lab, understanding mechanistically what are the bacteria and their metabolites doing to CAR T cells and how are they modulating the immune system. So in the final moments, I'm going to talk about the final objective interventions, including diet and lifestyle changes that promote a healthy microbiome. So one question that I often get from people whenever I'm giving a talk on the microbiome, particularly people who are somewhat familiar with the microbiome, not only just from science, but also in popular culture, one common question I get is, what can I do to enhance my microbiome? What about probiotics? So I want to show you some data from a study that was performed at MD Anderson Cancer Center by the group of Dr. Jen Wargo there. And this was specifically looking at a cohort of patients who received immune checkpoint blockade. And those are those anti-CTLA-4 and anti-PD-1 therapies. So they profiled probiotic supplement use in, yes, the lighter purple, and no, the darker purple, in patients who were receiving immune checkpoint blockade. And what you can see is that in patients who received or who were taking probiotics, their outcomes or probability of survival was worse. Not statistically significant because the p-value was 0.29, but there was a trend for a worse survival in patients who used probiotics compared to those who didn't. And we can talk about that more. But the thing that I think this highlights is really many of the probiotics are just different consortia of bacteria, but not necessarily highlighting the bacteria that the microbiome may need and that may be most important for the improvement of outcomes. And so just a word of caution that this data suggests as it relates to probiotic supplement use for at least in the setting of immune checkpoint blockade. This has not been performed in the setting of CAR T or allo-HCT, so we can extrapolate from this setting. The other thing they looked at is patients who had sufficient versus insufficient fiber intake. So I can't remember exactly what the threshold was, but just sort of promoting a high fiber diet and, keeping in mind that the amount of fiber needed to promote a high fiber diet is not unwieldy. It's definitely something that's manageable. So I think it was just serving the fiber throughout the day in each meal that was considered sufficient versus insufficient. And here's the citation if you want to delve into that more. What they found was that those patients who had a sufficient fiber intake compared to those who didn't, that they had improved survival. And so think of fiber as opposed to a probiotic that you're taking bacteria. Fiber is a prebiotic because bacteria use this fiber, they eat this fiber, and it helps to promote a healthy microbiome. So you're basically giving the bacteria the sort of sustenance they need to help to promote a more healthy consortia of bacteria. A group of my colleagues here at Stanford also really wanted to understand the impact of fiber or potential benefit of fiber versus fermented foods. You can see the apple versus kimchi. Kimchi is, I think, a classic example of a fermented food. And they did a diet randomization study for 36 adults, healthy individuals, who were randomly assigned to a 10-week diet high in fiber versus high in fermented food. And again, the amount of fiber versus kimchi, or, fiber can be, anything. We know we are all familiar with high fiber things, fruit, vegetables, whole grains, things like that. And kimchi is represented here, but other things high in fiber would be other fermented things. Fermented would be not just kimchi, but sauerkraut and yogurt and kombucha, kefir yogurt, those types of things. So they randomized patients to a diet high in one versus high in the other, and they controlled to make sure that those who were using on the high fiber diet were not eating a lot of kimchi and vice versa. So they could really have a clean assessment. And what they found was that the high fiber diet certainly did have some benefits, increased some microbiome function, and short chain fatty acids, etc. They did notice some changes in inflammation over time, but the high fermented food diet increased the diversity of the microbiome and also decreased inflammatory signals and activity, so was more anti-inflammatory in the gut. And so although both diets did show some functional benefits, they found that the high fermented food diet had some increased immune benefits compared to the high fiber diet that they thought were really of note. So there's limited data on dietary interventions and cancer immunotherapy. Much of this has to be extrapolated from other studies. It suggests that both a diet high in fermented and high fiber foods promotes a healthy microbiome. I think a diet really enriched in both, you can really incorporate both of these into your diet, would help to promote a healthy microbiome. And there's really no evidence to support the use of probiotics to improve the microbiome or clinical outcomes in this setting. The data that we have that shows that the use of probiotics for cancer immunotherapy, as I mentioned, although not statistically significant, did show a trend for worse outcomes in those patients taking probiotics. So with that, I'd like to conclude and thank our patients and fecal microbiome donors who helped to contribute to our research, my microbiome colleagues both at Stanford and UNC and Duke, my lab, funding sources, and here are the current members of my lab.
So with that, we will wrap up this session. I want to thank Dr. Smith for a very interesting presentation. Please contact BMT InfoNet if we can help you in any way, and I hope that you enjoy the rest of the symposium. Thank you.